Good afternoon. This is Erin with the Kentucky Department of Medicaid. It's not quite 1 o'clock and we're still clearing out the waiting room, so we'll give it just a moment before we get started.
Thank you.
Russ, it's just now 1 o'clock, but it looks like Elaine is just now logging in. So if you want, we'll give it just a second longer and then we'll be ready to go.
Okay.
Your waiting room is now empty.
Okay. Did Elaine get on? There she is.
She did.
Okay. So it looks like we've got a full TAC group here. This is Russ Rinaldo. I'm CFO at Owensboro Health and the chair of the TAC. Welcome everybody. And the TAC members want to go ahead and introduce themselves.
I'll be glad to start. I'm Michelle Lawless, CFO of MedCenter Health in Bowling Green.
Hi, I'm Elaine Yachts, Chief of Payer Administration at the University of Kentucky.
Good afternoon. I'm Lori Ritchie Baldwin, CFO of St. Elizabeth Healthcare.
Good afternoon. I'm Chris McClurg, Chief Financial Officer of UK St. Clair.
All right. Thank you all for being here. On the DMS side, do you know who we have here today?
Is there anyone in particular looking for? We have several DMS staff and MCO staff on today.
No, it's okay.
Okay.
Okay. All right, we're going to go ahead and get started. We've got a quorum. The minutes were sent out, the notes from the last meeting. I have a motion or to approve those minutes unless there's any edits or changes.
I'll make the motion. This is Lori.
Have a second?
I'll second the motion. This is Elaine.
Okay. All in favor for approving the minutes? Aye.
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 Any opposed? Okay, it passes. All right. We go to old business, NDC issues. Is Chelsea Free on?
Yes, I'm here.
So Chelsea, I've asked you to come today. Chelsea works at Murray, their health system there, and I wanted her to kind of explain some of the noise we're seeing in the NDCs. She's got a pretty good viewpoint of it. Will you introduce yourself, Chelsea, with your title, and go ahead and explain to the group what we're experiencing?
Yes, absolutely. My name is Chelsea Free. I am with Murray Callaway County Hospital. I am a health claim specialist, so I do all the billing for the hospital. And we are seeing a lot of denials for invalid NDC within the MCOs. And they are valid NDC numbers, but they're stating that since it is not on a list, that we cannot, that they're invalid. So it's pretty much how I understand it is that Medicaid, along with the MCOs, are telling us where we can purchase our drugs from, because the NDC, pretty much that is what it tells us, where it was manufactured from.
So the question I think we have is there a Medicaid NDC listing? Is that right, Chelsea?
Yes. I mean, the question, yes, I guess that is what I'm asking. There's a list, and I mean, there's also drugs that do not have HCPCS codes. And the list that I was given only has HCPCS and NDC crosswalks, but I mean, they are specific saying that the NDC does not go with this J code or the HCPCS code. So they are not, they're saying that it's invalid.
So I think the question I have for, and maybe we need to get some folks from pharmacy, but you know, we're seeing, and this isn't, Chelsea's not the only one. We've got others that are experiencing these denials. I know this has been active since last calendar year. I know there's been examples that have gone back and forth with DMS and the MCOs. And so what we're trying to understand is there an NDC list that for the hospital side that is out there from Medicaid, or do each MCOs have able to put their own NDC list together about what they're going to cover and pay? And if they do, why is that? So I'm trying to make sure we understand the process and understand what the offenses are, so that we can address the denials that we're seeing.
Well, this is Justin Derringer with the Department for Medicaid Services. We looked into this issue to see if it was maybe a policy issue from Medicaid side or standpoint. And what we found was that we don't require a lot of the same coding that the MCOs are requiring for this particular issue. If there is a fee for service or a traditional Medicaid issue, please send that to me so I can specifically look that up. But I couldn't find anything. So I believe this is a billing and coding issue for each MCO, that each MCO kind of has their own rules on billing and coding and exactly how they want those things billed. There's no list that's given out by DMS. So I think that's something that each of the MCOs would have to work with, exactly what they're requesting for those claims.
Okay. So, I guess my question I have off of that is that why is the NDC necessary for the MCOs? So the NDC reporting is so that the state can access rebates, and I would even challenge that under the state's methodology, they can't get those rebates because the outpatient is 95% of cost. So you're already getting the value in a 340B hospital of the lower cost drugs, and you've taken it below cost. But I'm trying to, why the MCOs get to dictate whether or not they're going to cover a certain NDC or not. So it's like saying they're going to be able to cover aspirin, but whether it's Bayer or Walmart generic, they're only going to cover one, and I've got to buy it from that source.
That was well said.
Another challenge that the payers have, this is really with that, or that the providers have with the payers, is each of them are using a separate list, and they do keep taking us back to pharmacy, but the pharmacy has the benefit of checking is this NDC on the list before we dispense it to the patient. On a hospital setting, we don't have that option.
This is not, yeah, this is, we can't confuse retail pharmacy with hospital outpatient pharmacy, and being, in a surgical setting or those type of settings. It's two different animals.
Right. We keep getting pushed back to the pharmacy, but they're not able to help us because it's apples and oranges.
So are the folks from the MCOs on here that can help me with this or discuss this?
Krista from UHC did recommend in the chat that we speak to the pharmacy team at DMS.
Yeah, Russ, it's Krista, and I can't figure out how to turn on my camera right now. Maybe I can do it. There we go. I'd recommend that the pharmacy team get involved. I think the reason this issue, I might be linking these things separately, but I think there was a shift in who manages the PDL and some of that component about the same time frame. So I suspect that might be related. But I think a pharmacy expert at DMS could really be helpful. I believe this issue came up with the pharmacy directors for the MCOs as well. There used to be a common listing, I think, as a part of that work. And then with the shift in who's managing the PDL for the department, every MCO, I think, did have to default to our own standard instead of having a standard across the state. I could be mixing issues, Russ, on that one, so I'm a little out over my skis, but I imagine the pharmacy team at DMS is much more well-versed on it.
Hi, this is a pharmacy director with Passport by Molina. And earlier this year, we were given instructions to pay outpatient hospital claims based on NDCs that were listed on the ASP file and the Palmetto Medicare file. And those were the only two sources of truth. So I do agree that, this committee probably wants to go back to the pharmacy department and discuss this, or also Jeremy, I can't remember his last name, is also able to help clarify that. But we were given those two sources of truth to use.
So what were those? Can you repeat what those two sources were? So,
yeah, it's a CMS ASP file.
Okay.
And the Palmetto Medicare file.
And that was direction from DMS to use those two sources?
Yes, ma'am.
Russ, we have some DMS pharmacy staff on the call that were able to join us. So they may have some input on that as well.
That would be great. Anybody from the pharmacy side on DMS can help shed some light for us?
Good afternoon. This is April Breaker, one of the associate directors with the pharmacy team. So in addition to those sources of truth that Harita shared, when we do get examples of other NDCs that may not necessarily be on one of those sources of truth, we do have MedImpact verify those new NDCs. And if they can find a valid HCPCS combination, they will add those to the list in like a supplemental list in addition to those sources of truth. So we will capture additional NDCs that may not necessarily be on those standard lists.
But are those the same sources of truth that are used? I thought we just heard that DMS claims traditional Medicaid does not use these standards. Did I miss that?
So with MedImpact, they will all go through those Palmetto, and then they have a kind of like a proprietary list that they also combine when looking at multiple sources. But if a valid NDC combination exists, then we do make efforts to identify and add that to the list if it does not come with one of those sources. There are a couple of others like RJ Health, and most of the lists are very similar, but there may be some nuances between them. But we do make efforts to add anything that's not there. So if there's a valid combo, we just need to find it.
And some of what we looked at, just to kind of clarify what you had asked, some of what we looked at in the cases that we were sent were straight billing issues that didn't necessarily have anything to do with an NDC list. They were MCOs requiring HCPCS, J codes, procedure codes, NDC. We don't look at procedure codes necessarily, just kind of just the HCPCS. So it's kind of two different things.
Oh, okay.
But we need to maybe have some specific examples, and we can get with pharmacy and see exactly whether it's a billing issue, because like I said, each MCO has a separate billing procedure and what they require. So what is it, a billing issue where the provider has maybe not included something they should have, or they're missing something and we just need to get that fixed and changed and updated? Or is it something where we have something that we need to add to our list?
And can I just clarify, this is for hospital billing, right? Pharmacy or drugs on a hospital claim, correct?
Yes, ma'am.
Yes.
Okay. Which is paid on a percentage charge, I would assume.
Yes, ma'am.
Okay.
And this is Chelsea with Murray. Every denial or every correspondence from the reps that we have received is stating that it is the NDC issue. They haven't advised that it's a billing issue with the HCPCS or anything like that. They are saying that the NDC is not on this list, so they can't pay it. We have provided examples to our hospital reps, and that is what we have received.
Okay.
But if there's sources of the truth from DMS pharmacy, then why are there separate lists for each MCO? Why aren't the MCOs just referring to those sources of truth from the pharmacies instead of having separate lists?
So we didn't require them to select only those sources of truth, because there are other lists that may have additional NDC combinations on it. So requiring them to only use one set of lists would alienate some of those NDCs that may be out there that are missed by one list. So the MCOs do have the choice to include other resources to identify valid combinations.
But not to exclude anything that are on those sources of truth.
Yes, they would not exclude. It's an addition type thing. So they wouldn't necessarily say it's on this list, but not on this list, so we won't pay for it. If it's on any of them, they can verify that. That's when we can allow for the payment. So it wouldn't be an exclusion from being on one list versus another.
Okay.
But if I'm hearing you correctly, and just this clarifying question, if there is a valid NDC code combo, it'll get added if it's not on the sources of truth.
That is the process that we are doing now. Yes. So we have those submissions, and if we get something where it says, well, no, our source really does say this is valid, MedImpact reviews that and then adds it to the list if they can confirm the validity.
But I guess, does that mean the provider has to pursue requesting it and then get it added to the list and then pursue separately the MCO pay?
So we do get an invalid HCPCS combination report. So it's not necessarily the provider should have to pursue all of those. It should pop up on that report where we send back to the MCOs to say, hey, can you fix these? These were invalid. Is there something that can be fixed, or are they truly invalid? Or is this something we need to look at and add a new NDC to the list?
And
what?
So okay.
I have a question. Whenever we as the provider provide information that these NDCs are valid, I provide the NDC that comes on the box or the, the paper from the manufacturer, and I'm still getting denied because it's not on this list. How do you suggest for me to move forward?
What is the, and maybe an additional question to that, what is the process? I don't know that I know the process or are familiar with the process to request that MedImpact
Review a certain combination.
review the combination that's being deemed invalid.
This is Billy with Baptist. I'm sorry, I can't figure out how to raise my hand on here. I seen somebody did, so I know it's an option, but I can't figure it out. I apologize. I snipped it into the chat where we did dispute the same NDC and received different responses from the same MCO. I just gave the NDC numbers, and then the response we got where it was an invalid combination and the recovery would remain. And then other ones that said, oh, it is valid, we're going to discontinue the recovery. So we would, in some of these, you got to remember, are $2.10, but other ones are $5,000 drugs. So the providers can't continue to chase this with 6 different payers differently. It's very impossible.
Okay, I can take that feedback back and see if there is a different way for providers to
So if we were able to identify some of these that are already on the sources of truth, then we would have a problem, correct?
Yes, if you're still getting invalid NDCs and there's no other billing issues, but you do find those on the source of truth, then that would represent a problem, yes.
Okay. Okay. All right. So I know I've got some notes on. We'll have to circle. I'm going to circle back with my folks and with others that have been talking today to dive into some examples. And then once we have those examples, is it possible for us to have before the next TAC to maybe to try to schedule a separate discussion with the pharmacy folks at DMS to go through some other questions or some of the things that we found?
Yeah, April, will you get us a meeting scheduled to go over what we've discussed and found before the next hospital TAC, and we can let everybody know. We'll come up with a formal. Well,
I'd like to be able to present some of those examples too, if we could.
Sure. Yeah.
And again, the whole goal is to understand how we address this and get through this to stop the denial churn on things that we think should go through cleanly.
Yeah,
Sure.
specifics
Can I
are
ask one more
important because
question?
there's a big difference between whether it's something it's just the NDC or whether it's being billed incorrectly.
Correct. And with the notes that we're getting, I know the messages we're getting back say invalid NDC, right? But again, we want to clarify what's happening and if how we can address it to make it better for everybody.
Russ, could I ask one more question?
Sure.
Did this just begin to occur when MedImpact came into play, or was it before or after? Is there any commonality in terms of timing?
My note said it's been active since November of 23.
So MedImpact would have become the new rebate vendor in January 1 of 2024. So it has always gone to a rebate vendor on the pharmacy side to look at those claims to make sure they are valid combinations. The previous vendor just had a different list or source of truth that they worked on.
Was that list more extensive? Perhaps?
Not necessarily. So we were just missing some of those those combinations. There wasn't a process to go through and add new ones. They would just deny claims or deny rebates on certain combinations because they didn't find it. So the state was just missing those before. So we had this new process so that we can capture more by adding new combinations each time.
Thank you, April.
And just to add, with that, the previous vendor had a proprietary list, so the intent for this new process is to have a level of transparency to try to work through some of these issues and be proactive.
Gotcha. Okay. Any other questions from TAC members or hospitals before we move on?
We appreciate your help. Thank you very
Jen.
much.
Thank you. Okay, the next item we have is retro authorizations, and I think they're also with new business under C, because I think we got a letter yesterday. Justin, is that right?
That's correct. There's a letter that you should have received that discusses retro authorizations.
Retro and split, right?
That's correct. Yep.
Can you help summarize it for the group, if you don't mind?
Sure. So there's actually two different letters that you should have received. The first letter talks about retro authorizations and split authorizations. It basically defines and specifies who is responsible for inpatient stays in a hospital. So those are always kind of hotly contested. And so there was a misunderstanding. So we wanted to make sure we clarify who's responsible for those inpatient stays. If an individual has Medicaid coverage when they're admitted to the hospital, that doesn't change. Even if they lose coverage at any point during their hospital stay, that applies for fee-for-service, as well as individuals covered by MCOs. If they gain coverage after admission to the hospital, the MCO or fee-for-service are responsible from the start date of that eligibility. And then the payment methodology doesn't change that either way, change that responsibility. So that was that part. The other part was about prior authorizations and explaining how MCOs and fee-for-service will not request any extra prior authorization. So if there is a prior authorization done for a procedure and that individual loses or changes from fee-for-service to MCO or an MCO to fee-for-service, or changes MCOs, that those procedures or services won't be denied for that and won't be requested a new prior authorization. So that was the first letter. And then there was another letter that went out, and I think you maybe addressed this a little bit later in the agenda, but it talks specifically about medical records. So one of the issues that was brought for us was, and we saw a couple of requests to providers to alter medical records. Of course, requests to change billing, maybe how something is billed or specific codes. Like I said, every MCO has their own way that of billing and billing practices. However, that should never include changing the medical record in any way, as you all know. So just to kind of specify that the actual medical record is totally separate from billing. And so that, I think that was getting confused a little bit at times. Those are the two that went out. We still have the issue of down coding that we're still reviewing and looking over. And so I know we've talked to a couple MCOs about that already, but we should have a letter ready to send out about the issue of denials for down coding. But that will be specifically about appeals and the appeal process. So that should be coming out before long.
Okay. So one clarifying question. So when someone comes in and they don't have Medicaid and they get Medicaid after the fact and it goes back retro to a date, or I can't secure a prior authorization for that, obviously, right? And so that is not required.
Right. So we would have to, I mean, talk specific, but so if that authorization, if that authorization's, retro, it depends on, I guess, the service. I mean, we'd have to go through some specifics there, but, so I think we're just talking about inpatient stay.
Right. And so if I've had patients, I think the hospitals have reported they've had patients that have come in and then they don't have Medicaid, and then they secure Medicaid after the fact, right? They're discharged and the application process goes through and they're secured back to the date of admission. There's an inconsistent process. We have some MCOs that do not require to go back and secure an auth to get that paid. You have others that do. And I guess the question is, in that situation, what is the expectation?
So that, and again, that's kind of left up to the MCO. It's going to be paid, but the actual process is going to be, the MCO can require that process, differently. We don't require that for fee for service, but they're allowed to provide that extra step if they feel it's necessary.
But they shouldn't deny the authorization.
That's correct. That's correct.
Okay.
Yeah.
All right. I think I'm clear. Does anybody else from the TAC have any questions on those two letters? Okay. Justin, thank you for the guidance in those letters. I appreciate it. Okay. So the soft denials issue, and there's a lot here. I want to try to unpack and make sure that I got it. So we have. So I know we looked at the behavioral health, just kind of set up an initial the behavioral health TAC. There was a presentation on prepayment reviews, and as I went through that presentation, the DMS put out, I understood that prepayment reviews, the MCOs had to get permission for prepayment reviews. There had to be it had to be approved, and then after a period of time, whatever that authorized time, if the error rate was less than 10%, they still had to get approval to continue that on. And I'm saying that because I want to make sure that I understand that, because as MCO, some of these requests to me and to others are looking like, and in fact, prepayment reviews. So we have the MCOs that use an Optum tool that scrubs the claims that come through, all the claims, and they pull out for a prepayment information. In the case of, I think, WellCare's presentation, it was 0.5% that they ask for medical records, and they get those medical records to review. So in effect, by using that tool, every hospital is under 100% prepayment review all the time, which kind of is contrary to the rules that DMS had put out or had explained in the behavioral health TAC. So I'm trying to understand how I can reconcile those two, because it doesn't seem to be consistent.
I didn't know if there's anybody from DMS that could talk about the prepayment review process. It's not my division, but
or one of the MCOs, if they want to talk about that tool and how that tool is, how they are not viewing that as prepayment review.
Hi, Russ. This is Dr. Cantor with United Healthcare. Some of our medical requests are for other purposes, such as there are other reports that we need to be able to validate for provider preventable conditions. Sometimes we ask records for that purpose. So they aren't always for prepayment reviews. And I'd be curious how well that's sorted out in terms of the medical requests, if a reason has been given. Sometimes it's for HEDIS chart chases, perhaps, depending upon the facility and the provider. But there are other reasons besides just prepayment review.
And I understand that. I think what the Optum CPI program is, and now it was presented again by St. Tean at the provider forum, said it was part of their fraud, waste, and abuse, and that they run all the claims through it, and they had 0.5% of total claims were stopped for CPI review, so stopped before payment. So they're scrubbing everything, as I understand it, through this Optum CPI program and looking for errors, coding, documentation, not medical necessity, and then are sending those back. And again, it's a prepayment review, and the percentage is low, that doesn't meet the DMS criteria of, to keep on a prepayment review of 10%. I mean, we're supposed to be notified. It's supposed to be very targeted for prepayment review, not a broad blanket. Retrospective review is a different story after you've paid, on the backside after you've paid a claim. But prepayment review, as I understand the DMS rules, is pretty specific. And the use of the CPI tool just comes off to me as something that's out of form of defenses that DMS has put for prepayment review.
Hey, Russ, the caution to use the definition prepay review, and maybe that's kind of the core, the crux of what you're getting to. I would say the CPI tool, if you really look into it, and Russ, I know you know the Optum team well, so I'm sure you're fully educated on it. One of the huge benefits that was went into the development of that tool was to, at point of claim submission, alert whoever the billing expert is that this claim is likely to deny, and here's why it's likely to deny. Here's your opportunity to correct a billing error before it's submitted. So the tool in and of itself, I think, was absolutely built in a way to try to help everyone's rev cycle and limit rework all the way around. But I think, to your point, I think we have different opinions on what prepay review is. Like when we file our program integrity reports with the state, none of the prepay savings can go on that because this is not a prepayment issue. This is a part of claims adjudication work. So I'm happy to take it offline on any UHC specific issues, and would probably lean towards the Department of Program Integrity at DMS to weigh on
this is Corey Kennedy.
Oh,
I'm
perfect.
part
Hey,
of the
Corey.
PI program. Can you elaborate a little bit more on on this process? So you're saying that the claims come through, and per the CPI tool, they'll be evaluated, and then if they say that they possibly could be denied for a reason, then is the provider alerted to that? I'd like a little bit more information on that, or we could take it offline, or sir, if you'd like to send me some examples of what you're talking about, I could look at them and then we could bring it back up or talk offline. I don't want to take up the meeting for my questions.
No, that's okay. That's why we're here. And Krista, I think I will. I mean, when I look at again, this is a Centene presentation, right? And it says claims chosen for review, and it says prepayment specifically as a bullet point. And then the letters are sent to a provider. So it's not kicked back. We're actually getting a letter where they're asking for records and claims. And then, so that it's not just a kickback error to somebody. It's actually, and so I think again, I think we need to dive into it further because, I mean, in the definition, I mean, it says it pretty much in a bullet point. They're doing prepayment reviews from the information that I've got that we saw in that presentation. So I think it's how they're using the tool. And maybe there's different ways to use the tool. But again, I can't get it to mesh or come together and reconcile what I'm hearing from DMS and what I'm hearing from the MCOs. They're using this tool on prepayment.
How many of the MCOs are using this tool? I know that you had said UHC.
So I know WellCare is.
Anthem is not.
Thank you.
I can't answer that. I don't know that off the top of my head.
Okay, so it's for sure WellCare and UHC.
I believe so. Yes.
Yes, Passport's also using the tool.
Humana is
And
not
so
either.
Humana is not. Thank you.
And so Aetna would be the one that we still need to find out.
And do you have examples or any information that you possibly could share with me, not necessarily during this meeting, but maybe
Sure.
via email?
I can. That's Corey, correct?
Yes, Corey.Kennedy@ky.gov.
I absolutely can.
Thank
I
you.
appreciate that. Thank you. Okay. Any other questions on that piece from the TAC members before I talk about the vendor request? So from a soft denial piece, what we're seeing is we're seeing some of the MCOs that the hospitals have reported that we're getting requests for medical records, but we have to go through a third-party vendor, and we have to wait for a barcode to be sent from the third-party vendor to the hospitals to send those medical records in. And so it's causing a delay, and those requests don't go to the same address. There's issues with those requests, finding those requests, people send in medical records and told because they don't have the barcode, they won't take the medical records. And so it's creating a delay and essentially a denial, an initial denial of a bill. And it's taken us longer to get payment. And I don't know that prompt pay interest penalties apply to that kind of what I'm looking at as a soft denial or not. And I may not be doing it justice. Maybe some of the other TAC members can chime in and help. But it's a real issue, and it's come up multiple times over the last few months from hospitals across the state.
So Russ, this is Nicole at Passport. We addressed that specific issue for Passport, meaning if we get the records, we are forwarding it on. And I believe all of the requests are happening within a short period of time, but we're happy to take any additional examples if you have them, or if the hospitals want to send them over for us to look at. We don't have any active examples right now on this process. And again, we made some adjustments because we heard that the hospital, especially at our KJ meeting, about being concerned that it might be going to Optum. So if they come to us, we are getting to Optum. Obviously the barcode is the quicker way to get them there, but we are working on continuing to solve for that at Passport.
Okay. All right. We'll get examples and to see if it's still out there. I know you weren't the only one that's using that vendor though.
Yeah, This is Billy with Baptist again. I apologize. I still haven't figured out the raise the hand thing. So with the Optum difficulties, the soft denial, our systems register that as a denial. So it gets processed electronically as a denial. The request from the providers is a way to automate this in some way. But with the paper request coming from Optum to a separate address, because that goes to release of information because they want the records instead of it denying for the medical records. Now, Passport has taken it to where they are forwarding them now. This is something we've been talking about since Optum came on the scene, honestly. But the other MCOs don't necessarily do that, which the only other one that we have a big volume of is WellCare. And then on the back end, when you get the partial payment, and then you have to wait for the findings report from Optum to tell you why you only, why this line and that line specifically denied. That's another administrative burden because you got information going one electronically and one paper. So we're looking for something, hopefully, that we can work together with the payers and they can get into and take what they want on the payer platform type situation, or, we just deal with them and they deal with Optum and send us back the payment with the finding report instead of them separately.
Hi, Russ. This is Rebecca Randall with WellCare. My apologies. I had some technical issues. I tried to speak up earlier. So I do agree with I think the earlier statement from Krista. I think there is a difference of opinion with regards to the CPI program and how it doesn't necessarily comport to the definition of prepayment review as DMS has defined it in our contracts. But we can have that conversation offline. To address, specific provider concerns, I would also request that if there are specific examples, we'd really like to see that, because right now we don't have anything open or active on the log. But, I will say that, of course, during our presentation, which I think it's my presentation you're referring to from the summits, we had a lot of positive provider interaction and feedback, not just from facilities, but also from the professional providers who also, again, this is globally applied from our perspective. We don't single out one type of provider versus another. But as a result of that, we've really taken to heart some of the requests and concerns. And we are going to be announcing several enhancements that we've been working with Optum directly on. Would like to talk more about that offline on an individual level because, quite frankly, all of us do things a little bit differently. But there will be some enhancements coming down the pike for us in early 2025 that will specifically address things like the paper trail, specifically enhancing the electronic portal. We've also made some adjustments to reduce overall volume of claim, even though, as you mentioned, the experience and claim tagging and concept tagging is Optum often refers to it, is very, very low. We're always looking at opportunities to partner with providers with things that make good sense. So just wanted to offer that up and offer again that we're open to those conversations and any concerns with examples that you might have.
That'd be great. Okay.
Just a comment. The last TAC meeting, examples were asked for. So I sent examples to Erin Vickers. And got a response that she received those. And I also got a response from, and I'm looking from Jeremy Armstrong DeRosset. I'm happy to send those examples again. And I also have examples. That particular example, I think, was with Passport. I can send examples with, or maybe it was from WellCare, and I can send examples for Passport and UHC as well. And this was related to the barcode issues and the letters and the addresses and that kind of thing.
Okay. Yeah, Lori, I don't think I've seen those. If you wouldn't mind, you can forward them directly to me, or I can reach out to Jeremy or Aaron at DMS.
If you don't care, this is Corey. I could reach out to Jeremy and Aaron also, but if you'd like to send them to me, you can.
Okay,
Corey, this is Nicole at Passport. If you get them, happy for, if you want to send them over to us, we can take a look.
and Corey, can you give me your email address again? Was it Corey.Kennedy at?
It's ky.gov and it's Corey, Corey dot, and it's Kennedy, just like JFK, at ky.gov.
Okay, I'm gonna forward you the email string right now.
Thank you.
All right. Anything else from any TAC members before we move on? Okay. All right, ED down coding. I know, Justin, you kind of alluded to this. You know, this is, we've got, I don't think it's limited to ED. It's happening in TNM codes and different things. But there's an AI algorithm program that is automatically down coding ED claims prior to payment. So again, this is prepayment review, in my view. It's actually, you know, taking and denying something prior to payment, not retrospective, not after the fact. And so that's the first issue with it. The second issue I have with it is there's no denial notice. There's not any detail to explain the reason for the denial and to inform, you know, the provider of the appeal rights and process. So, you know, the algorithm is not public. We can't see why something has been moved from a level 4 to level 3 or level 3 to a level 2. It's always down. There's never an up. If somebody is down coded or coded something inappropriately to the program from a down level, there's never an up notice. And so it's I can't process denials. It gives the MCOs the ability to use AI to do denials and payment cuts, and I can't. I don't have the ability to be able to dispute it because I don't know why. I don't know the reason, and so we requested in prior meetings. Again, this is old business that be looked at and addressed so that we can level the playing field a little bit. So we'll wait on, unless anybody has any other comments, we'll put it on the table and wait for the guidance so that we can talk about it at next meeting. Okay. Incarceration issues. I know we had a really good meeting and some discussion on incarceration issues, and I think we kind of stalled, and I was wondering if we could kickstart that off with another, potentially another, maybe a smaller group meeting to kind of reboot where we were at and talk about some of the things where there's education or presentations or things that we could do to try to alleviate some of those issues. Is there anybody on the DMS side that could help me work on scheduling a revisit of the call that we had with some of those folks?
Or Justin, you mentioned something that an ER downcoding letter would go out soon. Is that related to this issue?
No, I think we'd moved on from that to incarceration, but the down coding and denials without sufficient rationale is a issue that we're currently working on and looking into. And so there'll be some guidance on that later.
Oh, and I'm sorry that I went back to it.
That's okay. No problem. So for incarceration, I think I can make sure that we kind of get that group set back up if you would like, so we can address any issues that we're currently having with that.
Yeah, we had a really good call. It was pretty productive. We talked about some opportunities for education and presentations and to help with some of the jails and kind of clarify who's responsible for what. But it's kind of I haven't seen anything since then, and so I'd like to do that. And I'll reach out to the folks that were on that meeting as well. But
All right. Yeah, that sounds good. I know that, I think we were in the process of kind of formalizing a, FAQ and, kind of a policy page. And so I think that's kind of still where it's at, but, we can reconvene that. That's probably gotten maybe pushed.
Yep.
But we'll light that back up because it's in the final stages. We just need to push it on through, I think.
That's great. I appreciate that.
And we'd be glad, and again, I apologize for going backwards, but the incarceration is a really big issue for us, so we'd be glad to participate in any calls for work groups.
Russ, this is Erin. I believe I'm on those email chains. I will reach out to that group and see what we can do about getting that picked back up.
Thank you, Aaron.
And I think Leslie, Deputy Commissioner Hoffman was, working on that as well. So make sure to include her.
Absolutely.
Thank you.
And so the next issue going into new business is SNF coverage. So we're getting reports from hospitals that they can't get patients who need SNF care. And as I understand it, because the MCOs don't cover it, but fee-for-service doesn't cover it until after 1 month. So there's like a donut hole of no coverage, again, as I understand it, where the MCOs don't cover it, coverage for fee-for-service doesn't kick in until later, and the hospitals need to transfer it, and they are running into difficulty with the transfer because there's no payment source.
Hi, Russ. This is Melissa Carson with Humana Healthy Horizons. We do cover SNFs. The only thing that is not covered under their benefit is room and board, which is billed to the state. But we cover the nursing care, the 24-hour supervision. We cover physicians, physician assistants, therapists, oxygen, and other medical services for the first 30 days. And then all of it goes to the state.
And if somebody in the SNF that's billing it, are they in the room and board the biggest payment they would get, or the primary payment they would get for that stay? The actual SNF. And I'm a little over my depth here, but I'm just trying to make sure I understand it.
I think that's an answer for the Department for Medicaid Services, Russ. But
Okay.
I think your assumption is accurate. By contract, this is Samantha with Humana, it details that we're to cover the ancillary services for the first 30 days in SNF coverage and SNF care, but only ancillary, and that the rest is managed by the department. That's specifically how it's stated in our contract. So billing from a skilled nursing facility aspect would be directly to the department as it relates to the room and board. But I'm not the department, so
Right.
that's just what our contract says.
And I think that's what if we think we're running up against is that the SNF won't take them because it doesn't, that as I understand it, the coverage from DMS doesn't kick in until a month later. And that could be wrong, but that's what we're trying to figure out. And so your ancillaries would be, things like, a CT or something else that they needed outside of the room and board, but the primary payment, as I get it, is for the SNF is their room and board charge and their room and board day. And I don't know if somebody from DMS can look into that and see if we do have a hole, or the coverage does go when the person needs it and it needs to be transferred. it's creating placement issues, as I understand, from hospitals.
Russ, I'll take that back to our long-term care group. I don't see anyone on currently.
Okay. Okay, thank you, Aaron. All right, I'm just writing notes. Okay. All right, notification of payment rate updates. I think this goes back to a concern we had on some amendments that some hospitals got from one or two of the MCOs about when they would put rates in and when those would be effective. I guess the question I had for DMS was, when, if it's tied, like on inpatient, if it's tied to Medicare and Medicare final rule is at the end of August, how long does it take to, when are we seeing those rates being published by DMS? Is it after October 1? Are we getting them before October 1? If we get them before they're in effect, then it may take some of the concern or issues with some of these amendments that we're seeing.
This is Jacob Wilson with Medicaid. Are you talking about the DRM or DRG rates that come out in October?
Correct. So the final rule gets published. The final rule gets published in August. And so part of the concern is that we've seen amendments from various that says, okay, we're not going to load the rates until up to 30 days after we get notice of the rates, and we may not go back and retrospectively pay you those rates. And so I'm trying to understand if the final rule is out in August, when are we getting notice from Medicaid? And I guess I could go back and see when I got it last year. How long has it taken Medicaid to send out the DRG rate notices?
Yeah, we're usually sending those out around September. The rates are effective October. And we're also sending that month out to the MCOs.
Okay. All right. I'm going to take a look at the timing. I may bring back a concern, but look at the timing of some of those amendments. Anybody from the TAC? Any comments, questions on it? Okay. Split authorization. Justin clarified with the letters that were sent out this week. Partial hospital guidance. Make sure I understand what this is. Notes on this. Okay, in October 23, DMS issued guidance that partial hospital services would not be permitted to be paid if it were delivered by telehealth in the patient's home. And I know the Hospital Association requested this to be clarified. I know DMS was going to meet with CMS. Clarification that we got on July 2nd didn't address that concern, as I understand it. And KJ, the Hospital Association, sent another request on the 3rd. Do we know if that was received and from KHA, and has anything been looked at that?
That was received and it is being looked at. There's not been a decision made at this point, but it's being reviewed currently.
Okay. All right. Thank you. And then the last one, we got through the guidance this week and we'll take care of. Thank you for that. Any other items or discussion from the TAC members that you want to bring up?
I don't have any.
I don't have anything else.
Okay, hearing none, no recommendations, I think, right now. MAC meeting representation. I'm actually traveling at the next MAC. If one of the TAC members is able to present in my place, I'd appreciate it. I'll write up the report. If not, I'll figure out how to pull over on a travel and Zoom in to do it. But if you can, let me know. It'll be the fourth Thursday in September, I believe. Next meeting is on October 22nd, 2024. It'll be a Zoom meeting. On that, we will adjourn. I thank everybody for their time and their input. Have a great day.
Thank you.
Thank you.
Thank you, everyone. Have a great afternoon.
Thank you.